So wonderful to be here today and talk about our surveillance data. I know they did an introduction of me earlier, but in my own words, my name is Dr. Jasmine Zapata, and I am a board certified pediatrician, but I'm also a board certified preventive medicine and public health doctor. My job is to figure out how we can prevent death and disease from an upstream determinants point of view. I work clinically in the newborn nursery, and I actually deal with some of these issues in many ways, especially as it intersects with the perinatal population. Also, this is now my 5th year serving as the chief medical officer and state epidemiologist for maternal child health and chronic diseases at the Wisconsin Department of Health Services. This is now my 5th year, and I do a lot of work in our Bureau of Community Health Promotion and in collaboration with our Bureau of Communicable Diseases. So it's such an honor to be here to walk you through today our surveillance data for reported cases in 2024. I will go through the information and then we'll save some time at the end for questions. And we have a moderated, someone to help moderate the questions. So save your questions, write them down as we chat, and then we will come to them at the end. So as an introduction, just a broad overview of our reportable STIs in Wisconsin. We have chlamydia, and that includes disease classifications such as urethritis, cervicitis, and conjunctivitis. We also have gonorrhea, and that includes disease classifications as urethritis, cervicitis, and also resistant strains. And then we have syphilis, and the Wisconsin data that we collect includes all stages, and CDC data includes primary and secondary stages of syphilis. As a broad overview, our STI surveillance data is collected systematically through something called WEDS, what we call WEDS. That stands for the Wisconsin Electronic Disease Surveillance System. And the whole purpose of that is to monitor the frequency and distribution of STIs in the Wisconsin population. This analysis examines trends in reportable STIs in Wisconsin, excluding those from out of state or with unknown states of residence, to identify problem areas and allocate resources for effective STI interventions. We don't want to just collect the information. We want to use that information to prevent future cases, to help us allocate resources, and the biggest thing, guide and direct our interventions. The rates are calculated based on 2023 population data available in Wisconsin, Interactive Statistics on Health. That's our WISH population model. And for analyses, only confirmed cases of gonorrhea and chlamydia were included. So again, only confirmed cases of gonorrhea and chlamydia were included, while both probable and confirmed cases of syphilis were included. And just some information about surveillance data interpretation. STI data may be underreported.
We had one of our laptops freeze, so we're no longer presenting. So just a second.
I'm hearing a little feedback. Oh, okay, thank you. All right. STI data may be unreported, unevenly reported, and incomplete. And elements that impact the completeness include the following: practices and capacity of STI screening by healthcare providers.
Dr. Zapata?
Oh,
I'm so
yes.
sorry. It's Lorianne.
Oh.
Your video froze and we had to reboot.
Oh, okay.
You were on the intro slide.
Got it.
You
Okay.
read a couple of those bullets. I am so sorry.
No worries.
Right? Like, if
Okay.
you can go back to the
Yeah, no worries.
one or two. Yeah, we got to get all this other. There, you were here, but I think
got it. But everybody can. Okay, I need another wave again then. All right. Yeah. So everybody can hear me. Okay.
Now everyone can hear you. Thank you
so much. Apologies for that. Let me know if that happens again.
Will do.
Okay. All right. So big picture, our sexually transmitted infection surveillance data are collected through our WED system. The WED system stands for Wisconsin Electronic Disease Surveillance System, and that is for the purpose of monitoring the frequency and distribution of STIs in the Wisconsin population. The analysis examines trends in reportable STIs, excluding those from out of state or with unknown states of residence, to identify problem areas and allocate resources for effective STI interventions. It's really important that we do not just collect information for the purpose of reporting it. It's really important to collect this information so that it can help guide and direct resource allocation for effective interventions. One of the biggest things that I want us all to remember as we're going through this data is taking action. How can we use this data and inform the funding allocations that we're making decisions on, our strategic planning that's going on in our different regions? How can we intervene and prevent STIs? So that's just something to keep in mind, the importance of these analyses. And the rates are calculated based on 2023 population data in our WISH population module. For analysis, only confirmed cases of gonorrhea and chlamydia were included, while for syphilis, it was both probable and confirmed cases. So again, for gonorrhea and chlamydia, it's the analysis included only confirmed cases, while both probable and confirmed cases for syphilis were included. And just some general information about data interpretation. It's really important to note that STI data may be underreported, unevenly reported, and incomplete. There are certain elements that impact the completeness and accuracy of the data that include practices and capacity of STI screening by healthcare providers' compliance with case reporting, and then completeness and promptness of the case reporting. Additionally, COVID-19 may have influenced the number of cases diagnosed and reported in 2020 and 2021. So I want you to either put yes in the chat or wave your hand at me if you have experienced personally any reports of or personal experience with data being underreported or not being able to get complete data. Wave your hands, or put yes in the chat if you've heard of clinics or providers experiencing that. And I'm seeing some people wave their hand. And in the chat, we're having some people in the chat report that. So as we're talking about these things, again, I don't want to just come and present the data. I want you to be thinking, what are ways that we can improve in those areas? What are ways that we can collaborate and work together to be able to increase these reporting rates? Because the more we know, the more impact we can have. And this is our year of impact. All right, so now let's talk about some health equity considerations. STIs can affect anyone. However, some communities have much higher rates of infections than others. And these disparities do not include behavioral practices alone. There are many different social conditions, policy, and systematic practices that put some people at higher risk. There's many of them, but racism can play a role, discrimination, oppression, poverty, lack of access to sexual health education, lack of access to healthcare, and stigma. As I reflect on this topic and think about many of the clinical encounters I've had with birthing people who come into the hospital to have their babies, stigma is something that we're really working hard to overcome. There are many people that might be afraid to disclose information, especially as it relates to STIs, based on their past history, based on feeling judged or feeling like they can't trust us with that information. And so that's something that's very near and dear to my heart. As you look at this list, I want you to think about what's at least one thing or one initiative you can work on in your sphere of influence for this year in 2026 to even move the needle a little bit or continue to make progress in one of these areas. Again, racism, discrimination, oppression, poverty, lack of access
From
to
the health.
sexual health education,
Dr.
lack of
Zapata,
access. Oh, yes. Did I freeze
goodness
again?
gracious, so sorry. It happened again.
Oh, no.
And I,
I'm so sorry.
oh,
The
you lost
online.
about 30 seconds and you were on
Okay.
this health equity
Yeah, the
equalization
online
slide.
crew is saying I'm not freezing online. It's just in person.
Darn it. Well, we have the hotel on it, so
That's
we'll
okay.
figure
That's
it out.
okay. I'll keep rewinding if I have to. The
You
online
roll
group,
with it.
this is great for the online group to get the concepts reinforced. Thank you so
Fantastic.
much, online group. They're like, we're not freezing, keep going. But we're going to wait for our in-person team. So
Okay.
this is really important. I am going to talk about this slide again. Health equity considerations, especially for my in-person group. STIs can affect anyone. However, there are some communities that have much higher rates of infection than others. This is really important. These disparities are not just due to behavioral practices alone. That is key. The disparities are not just due to high risk sexual behaviors or behavioral practices alone. There's many different social conditions, policies, and systemic practices that put some people at higher risks. And this is just a list of some of the areas that come into play: racism, discrimination, oppression, poverty, lack of access to sexual health education, lack of access to healthcare, and stigma. Raise your hand, in person group. Wave your hand if you've seen one of those things come into play in any area of your work. Somebody in the front's waving their hand hard. Okay, I see you. I see you. And in my online group, put yes in the chat if you have seen it come into play. And so, my call to action, yes, I'm here to present data and talk about numbers, but I'm giving calls to action throughout this whole conversation. My call to action is for you to think about what is something that you can do, even small, in your sphere of influence this year to move the needle in one of these areas. What is something that you can do even this year to move the needle in your sphere of influence in one of these areas? Because collectively, if we keep working on it collectively, we can make a difference. Because remember, we don't want to just talk about the data, we want to think about action as well. So I challenge you, as you are finishing up this summit, as you are interacting with people, even the online group, as you are going back into your work throughout this week and the rest of the month, I challenge you to think about these areas: lack of access to sexual health education, lack of access to healthcare, stigma, racism. What are things that we can do? All right, so wave your hand in person if you're still with me, if you're not frozen. Let's see. Okay, I'm seeing a little movement. Can I get some more waves in person? Okay, I see some movement. So how does Wisconsin compare with neighboring states? All right, Wisconsin ranked third among neighboring states for primary and secondary syphilis, and this is described in rates per 100,000 people in 2023. So in our neighboring states, you can see that Wisconsin ranked third among neighboring states for syphilis. Wisconsin ranked fourth among neighboring states for congenital syphilis rates. And Wisconsin ranked fourth among neighboring states for gonorrhea rates per 100,000 people in 2023. Wisconsin ranked third among neighboring states for chlamydia rates per 100,000. And those are just important to think about in the context of the Midwest. And now let's talk about reported cases of STIs in 2024. Unfortunately, STIs are still widespread in Wisconsin. Apologies for if the formatting appears a little off, but a total of 31,576 cases of sexually transmitted infections were reported in 2024. And again, reportable STIs include gonorrhea, chlamydia, and syphilis. So again, a total of over 30,000 cases of sexually transmitted infections. Let's look at the trend over time. This is the number of reported cases of STIs between 2020 and 2024. Even though we still see a high number, we have seen a decrease, which is encouraging. So I want you to, and I know all of you all are in the fight and in the field. Sometimes we talk about problems, but we don't take time to pause and congratulate ourselves. So I want you, for the in-person crew, to give somebody near you a high five. Let's see, give somebody near you a high five. Say good job in the chat. For those, we have almost 70 people online. Say good job or great work. That is something for us to celebrate. Even in the midst of so many overwhelming public health issues, there are still bright spots for us to celebrate. So we've seen a decrease. It continues to decrease. It's been decreasing since 2021, and you can just see that trend here. Now, just because we're seeing a decrease, we still have high numbers. People's lives are still being impacted. So we cannot stop here. I want us to celebrate that there are positive things happening, all the phenomenal work that you all are doing in your spheres of influence, all of the work here at DHS and with our community partners, the work you're doing, it's working, but we still have more work to do. So let's celebrate, but also continue in this fight. Of the 31,576 STI cases reported in 2024, chlamydia accounted for 73.8%, followed by gonorrhea and then syphilis. So chlamydia is overwhelmingly the most common one, 73.8%. Let's talk a little bit about syphilis. Syphilis was the least reported STI in 2024. Primary and secondary syphilis rates. This is an overview of rates reported cases by jurisdiction in the United States and territories. And we can look at that comparison between 2020 and 2023. And so you can see that a lot of those areas that were yellow, where there was just 0 to 2 cases, over the last even just 10 years, you can see that a lot of those areas that were light yellow have now transitioned to that darker blue with higher rates. Syphilis rates increased in more Wisconsin counties in 2024 compared to 2014. So as you're seeing, when we talk about chlamydia and gonorrhea, rates been going down, but syphilis is something that we need to continue to watch very closely and continue our efforts about education, prevention, and awareness. And so this talks about between 2014 to 2024, a snapshot. A lot of the counties that were that lighter green, you can see the transition that is turning to that darker green. The rate per 100,000 population is definitely increasing. And we have a message from Lorianne that we've been having a few in-person hiccups, but we're going to just keep rolling as the virtual audience is reporting no glitches. All right. Okay. Compared to 2023, the number of syphilis cases in 54 counties decreased, increased in 14 counties, and remain unchanged in 4 Wisconsin counties in 2024. So when we think about over the last 10 years, we're seeing an increase overall for syphilis, but from 2023 to 2024, we did see some encouraging trends. So again, another way to look at it, the rate of syphilis cases has decreased for the last 2 years. Syphilis cases and rates per 100,000 people. So as you can see in 2024, The rate per 100,000 people was just around, in 2024, it was much lower. And then you could see over time in the 2015, 2016, all the way up till 2020, it started to go up. And then we had a huge spike in 2021 and 2022. But over the last 2 years, we have seen some encouraging trends that those numbers have been going down. So we're not where we were 10 years ago, but over the last 2 years, we have seen a decrease. And this slide talks about rates of syphilis decreasing significantly among males from 2023 to 2024. The rate of primary and secondary syphilis continues to decrease in 2024 as well. And this is giving an overview of that. So again, even though we still have work to do, we are seeing small moves in the right direction. All age groups experienced a decline in primary and secondary syphilis rates in 2024. So this gives an overview of rates of syphilis per 100,000 people by age in Wisconsin from 2020 to 2024. And as you can see, all age groups had a decrease. Some of the highest age groups impacted is that 20 to 29 year group and 30 to 39 year group. Those are the two highest impacted, but thankfully we have seen a decrease in those two groups and then all across the board. When we break it down by race, the syphilis rates has been higher among Black people. And that, going back to a few slides earlier when we talked about some of the systemic issues that are even outside of just behavioral alone, there are systemic issues that play a role in some of these trends. So as we're talking about this data, I want you to continue to just think about, what can I do? What more can I do? What strategies can we continue to lean into? What strategies do we need to pivot to be able to address the inequities that we see? So this just gives a snapshot about the rate of syphilis diagnoses per 100,000 people by race in Wisconsin, and really highlights the syphilis rates being much higher among Black Wisconsinites. And instead of just looking at these numbers, I really want us to ask ourselves the question, why? Why is this happening? And what more can we do? Black and Hispanic people are disproportionately impacted by syphilis. This is just another way to view the data based on the share of the population and share of syphilis infections. This gives an overview of our southeastern region, which continues to have higher rates of syphilis in Wisconsin compared to the western region, which is the lowest. Our northern region, northeastern region, and southern regions, our southeastern region continues to have higher rates of syphilis. So now let's talk about congenital syphilis. In 2024, 31 cases of congenital syphilis were reported in Wisconsin. 31 cases of congenital syphilis reported in Wisconsin. Milwaukee County accounted for 74 reports, 74% of reported congenital syphilis cases in Wisconsin. So again, Milwaukee County accounted for 74% of reported congenital syphilis cases. When we're saying these numbers and we're talking about this data, again, keep thinking about, what more can we do? How can we allocate resources? How can we work cross-collaboratively to work on these issues when we know the different races that are the most impacted? We know the specific diseases that we're seeing the highest rates in. When we look at the specific counties, what more can we do? And more than half of the reported congenital syphilis cases were in Black babies. And so this just gives an overview of that. Congenital syphilis cases reached an all-time high in 2024 since the last 20 years. So reported cases of congenital syphilis in Wisconsin from 2020 to 2024, look at that increase. That's a 520% increase from 2020. This is something that we need to continue to raise the alarm about, sound the alarm, especially as a newborn nursery doctor and a physician that has worked in newborn nursery. And I have unfortunately seen babies have bad outcomes from various sexually transmitted infections. There's even been situations where I've seen babies die from as a result of sexually transmitted infections that passed through the mother's placenta and reached the baby. This is something critically important. This issue is not just impacting the lives of adults, but now when we talk about congenital syphilis, this is impacting our most vulnerable, tiniest Wisconsinites. So congenital syphilis is something that we ask you to continue to bring more awareness to, continue to support in the fight for bringing awareness to and prevention. So now let's talk about gonorrhea. Gonorrhea is the second most common reported STI. A total of 6,852 cases of gonorrhea were reported in Wisconsin. This is a snapshot of our 5-year trend. And as mentioned earlier, we're seeing some decreases. This is the third consecutive year in Wisconsin our gonorrhea cases have been decreasing. And the gonorrhea rate has also decreased for the third consecutive year in Wisconsin. This is talking about our 5-year rate trend of gonorrhea cases per 100,000 people from 2020 to 2024. So again, bright spots. This is amazing. Let's keep any of the work that you're doing in this area as far as gonorrhea prevention and awareness and outreach. Thank you. Let's keep bringing awareness to that. And we want to celebrate these small wins and be thankful for that. This is a snapshot of our rates of reported gonorrhea cases by jurisdiction, United States and territories. So you can see that even though in Wisconsin over the last 3 years, we've been seeing decreases. When you look at a snapshot from 10 years ago, in general, the numbers have been increasing in a snapshot from 10 years ago. But if we continue with this trend, if we continue to all work together, we had an increase, but the last 3 years we've been seeing those gonorrhea's numbers going down. Let's keep that same fight. Let's keep that same determination. Let's keep that same enthusiasm about the trend going down, because my hope for our state, with your collaboration, our hope at DHS and our vision is that in 7 years from now, we can be doing the same presentation and do a snapshot and say, look, 10 years ago, the number was up here. Now it is down here. Who believes in that same vision? In the chat for our online attendees, let me know if you believe in that same vision. And I believe I'm unfrozen for the in-person crew. Wave your hand, a big wave in person, if you believe in that same vision. Okay, we have some in-person that believe in that same vision. Let's see if there's anybody online that's still with me that believes in that same vision. Just because we see statistics that can be harrowing or bring us down, it doesn't mean that that needs to be our story for the future. Let's look at this data so we know what work we still need to do. So my vision is when you invite me back in 10 or in 7 years from now, we can look at some of these same snapshots and numbers, and we can look at the powerful change that we see collectively. We're on the right track for gonorrhea and chlamydia. A lot of work to do still with syphilis. All right, so gonorrhea rates increased in more Wisconsin counties in 2024 compared to 2014. We talked about that. But just because we see that that increase doesn't mean it needs to stay that way. So that's the change over the last 10 years. But over the last 3 years, we're starting to see ourselves move in the right direction. Compared to 2023, the number of gonorrhea cases decreased in 39 counties, increased in 29 counties, and remained unchanged in 4 Wisconsin counties. I'll leave this up for just a second so you can look at the various counties. You can look at your sphere of influence in the areas that you're working. This is just a snapshot so that you can see. The light purple were counties that compared to 2023, the gonorrhea cases decreased. The darker purple is reported gonorrhea cases, counties where the reported gonorrhea cases actually increased. And then that gray is unchanged. Let's talk about gonorrhea rate among both males and females. That when you look at gonorrhea rate for males and females, that's been decreasing since 2021, another move in the right direction. And our overall trend of gonorrhea by age group, this is what we have been seeing. In our younger age population group, that 15 to 19 years old and 20 to 24 years old, that's when we tend to see some of the higher rates. But in the different age groups, for the most part, we've been seeing it either over the last from 2022 to 2024, either stay the same or decrease slightly. So let's continue moving. I want to see this completely go all the way to zero. And we can make that happen if we continue to work together. The rates of gonorrhea are slightly higher among males between the age of 15 and 19 years old compared to same age females. So as we're talking about this information, especially as we look to that 15 to 19 year age group, and we see that the rates are slightly higher among males, I want us to think about, why is that happening? What more can we do? I have 4 children between the ages of 2 and 16. So I have a 16, almost 17-year-old son. I have a 15-year-old daughter, an 8-year-old girl, and then a 2-year-old boy. And man, let me just tell you, the last couple months and last couple years of high school, my conversations with my teenagers have been very exciting and interesting. And we talk about this all the time. A lot of times they're like, "Oh, mom, we don't want to talk to you about this." But sex is a very common conversation, talking about STDs, talking about healthy choices, talking about consent, talking about just your overall health and wellness in the context of reproductive health. And that's just something that I hope that every family in Wisconsin is having with their children, even if children are unable to have those conversations safely at home. What kind of conversations are we having in our schools? What conversations are we having in our communities? How do those things play a role? So as we look at these numbers, again, I don't want us to just look at the data. I want you to think about, what more can we do? How can we reach out in a way that is engaging and a safe space to talk with males between the ages of 15 to 19 about gonorrhea? So that's something I just want you to be thinking about and exploring as you continue in this fight. Gonorrhea rates have been declining across all races and ethnicities since 2019. We still see inequities, especially among Black Wisconsinites. The numbers are still much higher, but since 2019, we have been seeing a decrease. So we still have a lot of work to do, but there's still positive and bright spots. And again, gonorrhea doesn't impact people of all races and ethnicities equally, and we talked about that. Now I will share about chlamydia. Chlamydia, as we mentioned earlier, is the most common reported STI. A total of 23,308 cases of chlamydia were reported in Wisconsin. The reported number of chlamydia cases decreased for the third consecutive year. So again, we're proud of that positive trend. We still have so much work to do, but we do have to celebrate our wins. And one thing that is important to ask, we might not have all of the exact answers, but it's important to ask ourselves, why are we seeing decreases in chlamydia and gonorrhea rates, but we're seeing increases and we're seeing some concerns in the area of syphilis, especially related to congenital syphilis? What can we learn from our recent wins in the areas of our chlamydia and gonorrhea cases going down slightly over the last few years? What kind of outreach and education are we doing? What are the areas that are helping us with those wins in that area? And are there ways we can translate that into other areas? So, chlamydia has decreased for the third consecutive year. Again, instead of just looking at this data, I want you to take away from this. I'm going to say it over and over and over again. How do we take this data and move it into action? How do we take this information and translate it into our everyday work? How do we take this data and use it to prevent future cases? And we won't have the answer to that question today, right now, but that's something that we just encourage you to think about. And this is just another visual of how the rate of reported chlamydia cases have been decreasing for the last 3 years. So a move in the right direction, but we still have a lot of work to do. Just like we looked at for gonorrhea, this is a snapshot of reported chlamydia cases by jurisdiction in the United States and territories from 2014, and then a snapshot from 2023. So this isn't as significant jump as we've seen for some of the other STIs that we've discussed, but there are still more states and jurisdictions that are moving to that dark blue area when we want to actually be moving more in the opposite direction. But that's our 10-year snapshot. And this is Wisconsin specific data from 2014 to 2024. This is the changes that we have been seeing from 2014 to 2024. And just as we analyzed for gonorrhea, here's our county specific data for chlamydia as it relates to if we're seeing cases increase or decrease. So in Wisconsin, the number of reported chlamydia cases in 2024 compared to 2023 decreased in 51 counties and increased in 20 counties and remain unchanged in one county. So you can get a visual of the light blue is where it decreased, the darker blue is where it increased, and then that gray area is no change. And this is really important too, as we're analyzing our state-specific data to look at how certain, we talked about earlier, how the southeastern regions were impacted by certain trends, but then also we should also be thinking about how rural areas are impacted as well. Wisconsin recently received our first year installment of a hopefully 5-year award from the federal government, from CMS, for our Rural Health Transformation Program. And that Rural Health Transformation Program is focusing on 3 key areas. And the first area is on how we can increase our workforce capacity to improve the health of rural Wisconsinites. Number 2, focusing on enhanced technology. How can enhanced technology and increasing our digital capacities, how can that help with rural health inequities that we see. And then the third area is um, cross collaboration and care coordination. And so Wisconsin was just recently awarded $203.7 million for our year one of funding, hopefully the first year of a 5-year total award, over $1 billion coming into the state of Wisconsin over the next 5 years to focus on rural health. And when I look at maps like this, that's just something that comes to mind. We see that some of the areas that have increased, a lot of those are rural areas. And so just asking questions, how does that play a role? How does workforce capacity, technology, care coordination, how healthcare access, how does that play a role? So those are just some of the things that I think about. And those are some of the things that we encourage you to continue having conversations in your areas of influence, in your day-to-day work, so we can come up with solutions. Again, we don't want to just look at the data. We want to ask ourselves, what is this data telling us? And how does that impact our everyday work? How does that impact our strategic plans? How does that impact our funding allocations? How does that impact our community conversations? Who else needs to be in the conversation? And if you want more information on the Rural Health Transformation Program, that is on our Department of Health Services website. If you just put in a search of Rural Transformation Program or Wisconsin Rural Health Transformation Program, there's a website that gives details about all of that. All right, and I can go into that more during our Q&A time. All right, so chlamydia rates have historically been higher among females compared to males. And so that's just giving an example of that, just showing some of the trends for the chlamydia rates being higher and the overall trend of chlamydia by age groups. And I'll let you look at that. This is the trends that we've been seeing from 2020 to 2024. Again, some of the highest age groups for both chlamydia and gonorrhea is that 15 to 19-year age group, and then the 20 to 29-year age group. It's not as prominent for that 30 to 39 and then 40 plus age group, but something that's encouraging, we've been seeing a slight decrease over the last few years, especially in that 15 to 29 age group, but it's still much higher. So what is that telling us? Where can we target our efforts? What conversations do we need to be having? Who do we need to be bringing on board? And the incidence of chlamydia was higher among females than males aged 20 to 29 in 2024. And you can see that visually here. The rate of chlamydia infections increased among Black people from 2020 to 2023. And this is showing our rates of chlamydia diagnoses per 100,000 people by race and ethnicity. So Black Wisconsinites numbers much higher here and have been slightly increasing compared to other populations. We still have much work to do, and we need to be asking and really digging into why. As a preventive medicine physician, in our training, after I did my traditional clinical training in pediatrics, I did an additional 2 years to become board certified in the field of preventive medicine and public health. And one of the biggest things that we always ask ourselves is why, at least 3 times. So we'll say, why has the number of chlamydia infections increased among Black people between 2023 and 2024? And even when you start to identify certain things, certain factors that play a role, you don't stop there. You dig into and say, well, why has that been the case? And then you keep going deeper and deeper and deeper until you can really aim to get to the root cause. And that's what I encourage us to continue to do. Continue to dig deeper. Let's ask questions. Let's continue to have studies to figure out how can we overcome some of the racial and economic factors that play a role. How can we reduce stigma in the healthcare system? How can we rebuild trust? with certain populations in our healthcare system. That's something that we need to continue to talk about, continue to research, and continue to make moves in the positive direction. So, overall, some of the key takeaways for our 2024 data: the number of reported cases of STIs decreased by 6.6% from 2023 to 2024. Of the three STIs, syphilis cases have decreased the most at 21%. However, as we mentioned before, the number of congenital syphilis cases rose last year by 24%. So, who needs to be in this conversation? Who else needs to come on board? Who do we need to collaborate with? How can we do even more to address not just gonorrhea, chlamydia, and syphilis? Who do we need to engage so we can prevent these increasing rates of congenital syphilis? How can we have more conversations, bring more awareness to that? How can we collaborate even more with birthing hospitals and facilities, with our obstetrics colleagues? How can we get more information and collaboration with doulas and people who are community health workers who are working boots on the ground with pregnant people? How can we bring awareness to this before someone even gets pregnant? From a life course perspective, what are things that we can do? So, more than just the key takeaways, I want you all to be thinking about how can we take this information and take action. That is the theme of this year: action. We're so thankful. I'll stop sharing my screen there. We are so thankful for everything that you've already been doing in your respective areas. And I want to really highlight that, because sometimes it can be heavy working in the field of public health. Again, I want you to put in the chat for my online viewers, put yes if you've ever felt even a little heavy or burnt out working in the field of public health. For my in-person, give me a big wave again if you have ever felt heavy or burdened or just discouraged. I know every day I wake up and turn on the news, especially in the field of public health, I can have a tendency to feel discouraged. But I want you, my hope for everyone who is here, I want you to remember that when we all work collectively together, we can make a difference. We can't do it all alone. And sometimes it can feel heavy when in your area of influence, in your job, in your county where you are located, it might feel like the weight of the world on you. But if you continue to do your part and the person next to you continues to do their part and we all work together, we can see changes in the right direction. So let's celebrate, because there are things that we've seen from this recent analysis where the numbers are going in the right direction. However, there are some areas that we're seeing, okay, we need to do more in these areas, especially in the area of congenital syphilis. But together, we can make a change. Wisconsin is so strong. Wisconsin has overcome so much. We can make a change. So don't be discouraged. Let's take time to celebrate the things that are working, and let's continue to have a continued powerful effort to change some of those statistics that are moving in the wrong direction. And I will stop there and hand it over to Lori Ann. Thank you so much for allowing me the opportunity on behalf of our STI team and on behalf of Department of Health Services to come chat with you all today.
Wow. Thank you. Thank you so much, Dr. Zapata. You make data and statistics fun for even the people that don't like them as much. So, hey, we appreciate that. I have the first question in the Q&A. What are the reasons we may be seeing more gonorrhea in males over females? Could it be due to the fact that males may have more noticeable symptoms that brings them to the clinician?
Great question. Can you repeat it just one more time?
Sure. What are the reasons we may be seeing more gonorrhea in males over females? Could it be due to the fact that males may have more noticeable symptoms that bring them to the clinician?
That is a great question. That's a great question. The data that we collect can't give that exact answer based on our surveillance data. And that is why we collaborate with you all. We collaborate with our clinical partners, collaborate with people who are boots on the ground, community health workers, people talking with people talking with individuals who are impacted to kind of come together to think through exact questions like that. So we can't tell exactly from our surveillance data the exact 100% reason why we see that, but exactly what you mentioned, that can be something that's playing a role. Men definitely have more noticeable symptoms of gonorrhea. A lot of times in women, gonorrhea and chlamydia can be silent and it's not as obvious. And so we, in fact, might have underreporting. There might be a lot of women who have it, but they never went in to be tested. Versus, as mentioned in men, there are more noticeable symptoms. So that could play a role as well. Definitely, we don't have the exact answer based on our surveillance data, but that is something that makes a lot of sense. That's why it's so important to have collaborative discussions. Who do we need to bring to the table to answer that? Talking with our healthcare colleagues that are boots on the ground treating infections, that would be good to talk to them to say, what are you seeing in your clinics, especially some of the counties that we see that are more impacted? How can we have conversations with them and bring them to the table as well? That would be something that would be really interesting. Great question. Thank you.
Yeah, we have Craig Berger here from our STI unit.
Hi, everybody. Craig Berger, Syphilis Surveillance Coordinator for the state. Hi, Dr. Zapata. Thank you for coming with us today. I know congenital syphilis, the big scary number is that 31. I do also want to point out that we had a lot of wins. If you don't know, congenital syphilis is in 4 scenarios, basically, from the CDC. The 1s and 2s are the bad ones. The 3s and the 4s are wins, because those are ones that are impacted prior to the pregnancy or impacted early in the pregnancy to stop a congenital syphilis infection from occurring. And that's because of the hard work of the DIS across the state. Unfortunately, we've lost so many now because of budget cuts, but that was over 100 of 3s and 4s. So there's definitely 31 is really bad, but also we can look at the wins of the 100 where we had really good impact on.
Thank you. Can I ask you, don't go anywhere. Can I ask you a follow-up question, please?
Yes, of course.
I know you're supposed to be asking me questions, but I want to ask a follow-up question just to really emphasize that point you said. Thank you for sharing the wins, because a lot of times, sometimes when we see numbers moving in the wrong direction, there's still wins to be celebrated. Can you talk about what you want to see, or think needs to be done to continue and expand on those wins across Wisconsin? I would love to hear that, but I also want all of the audience members to hear that as well from your point of view. How can we amplify those wins that we did see?
Oh boy, I would love that question an hour ago so I could have thought on it. I think one of the biggest things that we really have to push, especially as public health professionals, is early intervention, early testing in the pregnancies. Wisconsin is one of those really weird states where we don't have a law that requires prenatal testing for syphilis. 2-3 years ago, with the increase, we did put out a HON saying we want testing at the first prenatal visit, 28 weeks, and at delivery. However, most of the folks that we're finding who have scenario 1s, which is like the worst case scenario for congenital syphilis, are folks that aren't in prenatal care. So that's one of our biggest things, that we really have to focus on getting folks into prenatal care early so that we can get early testing. The amount of syphilis used to be an MSM disease. There's no better way to say it, but it's really leaked into cisgendered females and whatnot as well. So we are investigating a lot more infections of pregnant people. So we're going to have a lot more cases, unfortunately, right now, just due to the way that it's spread. But I think with early intervention, early treatment with penicillin, that's the only thing you can use with people who are pregnant is penicillin. And unfortunately, we're also having a shortage of penicillin right now. So a lot of things are working against us. But if we just keep moving forward and getting folks tested early in the pregnancy and getting them treated, we know we can really lower the severity of congenital syphilis. Was that a good answer for you, Dr.
That
Zapata?
is phenomenal. Thank you so much. That's great. I wanted everybody to be able to hear that so we can all put our intel together. I look at that as intel. I look at the way that I approach public health and a lot of other, even personal health issues of different family members that I've worked with, patients that I've worked with, obstacles in my own life. I look at it as if we are in war. Okay. We are all an army of public health professionals. We are all an army that's going to come together so that we can attack and overcome the different health issues in our state. That's what all of us are. We're an army, and everyone has different skills that they bring. There are people who are really great at community engagement and education, people really great at looking at the statistics and data and doing the analysis for the surveillance tools. There are people who are really good at the media or the medical side of it, treating. Everyone plays a unique role. Every single one of you who are watching this live, even watching the replay, we all play a specialized role, but collectively we are in an army. But in order to be able to defeat our enemy, we have to have intel, and we need to hear what other people are seeing. So when you just shared what you're seeing from your very important role, and thank you so much for what you do, and you're sharing what you think needs to be done based on what you've been seeing, that's intel for all of the rest of us. So we could come together and we can win. Yes. Okay. We're gonna win. I look at this, when I look at these numbers and trends, I look at it like we're in a battle. We're actually on the battlefield and we're analyzing our enemy so that we know how to attack. We're not going to get this intel just so we could be stressed out and worried, even though it's okay to be a little stressed out, because I get stressed out every day in the world of public health. But we're not going to stop there. We're going to use this intel that we're getting to communicate with each other what we're seeing and make a change. One thing that I wanted to share, especially when you mentioned access to prenatal care, I would like to share, and we're still in good timing, I want to share a little bit about some of the research that I did as it relates to Black birthing people and health outcomes, birth outcomes. So in my area of research, I was able to do qualitative interviews with several Black birthing people to ask, why are we seeing so many inequities among Black birthing people compared to non-Black birthing people in our state, and particularly the county in Dane County, which I was looking at. But I just asked that question as a whole. We see that, especially the data that we just looked at for congenital syphilis rates, we've seen the highest rates in Black birthing people. And so something that was just mentioned that was really important is a lot of times the cases that we see are among individuals who had no prenatal care at all. So remember, we want to ask the question as public health defenders as public health preventionists, we want to ask ourselves, well, why? Why is there less prenatal care? And studies show that Black birthing people utilize and have not only less access to, but less utilization rates of prenatal care compared to non-Black individuals. The question is why? Even if you have access and your insurance covers prenatal care, there's less utilization. And the question is why? We need to be digging into that. So in my body of research, I took that exact question to say, why are we seeing less prenatal care usage? Why are we having higher rates of preterm birth, higher rates of infant mortality among Black babies in our state? What do you think the reason is? And let's talk to the individuals most impacted. That's something that I encourage in all of your work that you're doing. We continue to ask the individuals most impacted for what they think is the solution. just as important as any peer-reviewed study or expert with multiple degrees from high-level institutions being the expert, the people who have the solutions are those most impacted. And I encourage you, all of you all in your areas of influence and your areas of work, always be thinking of how can we bring in the voices of those most impacted? How can we talk to those 15 to 19-year-old boys where we're seeing certain STIs increase in? How can we really hear the voices of those impacted in the rural regions? And then especially in this case, for our congenital syphilis cases, which we see higher among Black birthing people, let's hear the voices and what are they saying? So that's what I did a few years back. I asked Black birthing people, why do you think that we have such high rates of birth outcome inequities? And one of the key themes that came out and key desires was a desire to have better communication with your healthcare provider. When I asked Black birthing people, why is there a lower utilization of prenatal care? Because that's really important. One of the biggest things was perceived experiences of stigma when you go into the healthcare facilities. And then also feeling like you don't have enough time to build a relationship of open communication and trust with your provider. I want you to give me a big wave or put yes in the chat if you ever went to the hospital or to your doctor and you felt a little bit rushed. Don't feel bad that I'm a doctor. I can handle it. Give me a big wave or put yes in the chat if you ever felt rushed when you went to the doctor. Okay? So if we're all feeling rushed, imagine if there's already a population that there are reasons, and I won't go into all of that now, but if you look over even the last 100 years, there are justifiable reasons that certain communities and populations have a higher level of distrust with the healthcare system. So that was one of the key themes that came out of this qualitative research that I did. One of the big desires was to be able to have more time and better communication with their healthcare providers. Okay. Another key theme that came out and was identified as a community-driven solution to how can we get more Black birthing people to trust the healthcare system and engage more. So number one, spend more time, have better communication. And then one of the third big themes that came out was there was a overwhelming desire to have the healthcare workforce reflect the diversity of our communities. Right now, that is not the case. The diversity in our state is not reflected in our healthcare workforce. So there were many Black birthing people that said, when I come into a facility, it would be nice to see at least a few people who look like me, where I feel more welcome just coming into a healthcare facility and having providers or having healthcare staff that look like me. And so those were some community identified solutions of how can we increase trust with Black birthing people and the healthcare system. And what does that have to do with STIs? What does that have to do with congenital syphilis? One comment that was just mentioned was that prenatal care is critical and important, being able to catch those cases of congenital syphilis so that you can intervene before it's too late. And so I'm sharing that information with you from my own research. So hopefully you can just ask yourself, we're not going to have all the solutions at this moment, but you can ask yourself, what more can we do to increase trust with Black birthing people and the healthcare system? And based on the powerful birthing people that I was able to interview, their voices are so important. Here were three specific solutions that they said, this is coming from the people who are most impacted. Number one, spend more time with us. We need more time, longer visits. We don't want to feel rushed. Spend more time with us. Number two, develop even better forms of communication. And number three, we want to see the healthcare workforce reflect the diversity of our population. So I'll stop there. But I just wanted to share that with you because remember, the theme of today is action. Don't just take these statistics. I want you to be thinking about how can I take these statistics and implement it into my everyday actions so that we can save future lives. All right. Sorry.
We do
Back
have
to
some
you, Lorianne.
questions. Yeah, we do have some questions in the chat now. I wasn't able to see them earlier.
Okay.
But here's one that says, how do we address barriers to care when testing and treating STIs?
Yeah, great question. How do we address barriers to care? Sometimes we can do more harm than good when we find something, but we can't do anything about it. That can cause more ethical and psychological harm when we find out a test result, but we don't have the capacity to make a change. And so there are many things that we can do to work on this issue, continuing to continue to advocate for funding. There's a lot of threats right now, just in general, to public health funding and surveillance. So continuing to raise our voice about the importance of funding so people can be able to get access to health, the important health care that they need. Number two is collaboration. Collaboration not only with traditional hospitals and clinics, but collaboration with our community-based providers, figuring out ways that we can do warm handoffs. That's one of the things that personally I wish we could do even better job at. But that's a strategy that I believe we have a lot of room for improvement, is warm handoffs. Instead of just saying, here's your after visit summary, here's 10 numbers you need to call, good luck. What if you can have that person that's going to be the next one to help them in their treatment or care plan? What if you can have a representative meet you right there at the clinic to do that warm handoff? Even if it's not in person, what if there could be a virtual visit between the whatever individual is who is doing the diagnosis, and then the next step, the person who's going to help them with their treatment plan? What if you can get everyone together in a conversation, even if it's virtually? What are better ways that we can do warm handoffs? Even if you're connecting someone with a community resource, what are ways other than just printing out an after visit summary or giving somebody just a list of resources? How can we have them on the phone with someone and say, hey, we're going to call together. This is someone I really trust. Let's call together. I'll wait here until I know you got an appointment on the books. Let me help you if you need some support. Those are just some of the things that I think we can take to the next level as far as warm handoffs. Community health workers are going to be really important in this fight, but we need funding for community health workers. I'm really, again, thankful for some of the amazing things that are happening in our state's rural health transformation program, where there's a lot of initiatives to fund and help expand our community health worker workforce. And again, I won't go into it in too much detail, but uh, our rural health transformation program funding dollars that we just received in Wisconsin, I am very hopeful that that's going to do a lot of tremendous work in our states as far as some of the rural health access barriers that we see. Great
Thank
question.
you. Another great question here. Menominee County has consistently had high rates of STIs, especially chlamydia, every year. The tribal clinic does a lot of STD testing, including going into the schools. The patients are open and receptive to testing, whereas surrounding counties do not test as much, which seems to play a role in causing the rate in Menominee County to reflect higher numbers. So a high rate of testing is going to reflect higher numbers. It was more of a comment but if you'd like to comment on that.
Yeah, I will comment. That is the case where we see places that have higher amount. This happened a lot in COVID. Okay, a lot of places that did a lot more testing, we saw higher rates of COVID because you're just essentially testing more, and that's just something naturally that happens. But I would say it. I mean, great if if we know that something exists, we have an opportunity to treat it. We have an opportunity to bring more awareness in those areas. So sometimes when the numbers go up, that's a great reflection. It might not always reflect behaviors that are changing or the actual incidents going up. It might just be that we're doing way better at testing. So even though it can seem negative, that's a positive, because that's more cases that you didn't know, more cases that you know now that exist that you can do something about. So that's just definitely a good reflection that sometimes counties with higher rates is because they are doing more testing. Now, something that would be really important to note in those counties is, okay, now let's look over the next 10 years. If you sustain that higher level of testing, now what are our trends? Okay, it's great that you've been doing more and more testing, but once that level of testing kind of gets at its peak, you're going into the schools, in the communities, you've maximized the like levels and efforts of testing. Now, what are those rates doing? Are they starting to increase, stay the same, or decline? Then you can interpret you can interpret it in a better way. But yeah, once you switch over to like changing your amount of testing, that definitely can impact if a county has had increased or decreased cases. Great observation. And
Thanks.
those are just some reflections on it.
Next, we have Chelsea Watry from our STI unit. Here she is.
Thanks,
Thank you.
Chelsea.
I'm a DAS, so I work hand in hand with Greg. I just wanted to just expand slightly on what he had mentioned, especially when talking about congenital rates, is that I also think it's important to think about we need to continue to address and acknowledge social needs and other needs. And I think that where that's a lot of other people in the room that maybe don't do as much direct with syphilis, that we need to continue to address and talk about houselessness and substance abuse, and really continuing to address those needs, because we know that when other people's needs are met, then that also can contribute to people having access to care, people getting into prenatal care as well. So I think especially a lot of other programs that you all are involved in within your local tribal health departments organizations are really important, and we need to continue that work because it is all interconnected. So I think that really can also have an effect on our congenital rates. So that's all I want to say.
Thank you. Let's give a big clap for Chelsea. Everybody, please.
Thank you.
Please,
Thanks.
please. Yes, yes. Great point.
Next item. Given that many cases go undiagnosed and probably also underreported, etc., how do you estimate the true prevalence of chlamydia in the population? Any thoughts on that?
That's a great question. There's no perfect answer. We have to use the best surveillance tools that we have. In one of the earlier slides, it did acknowledge that there are many cases that go underreported. There are some people who don't know. There's some issues with reporting. We just have to keep raising awareness for the importance of recognizing signs and symptoms, getting appropriate screenings done. That's all we can do. But because there's probably several more cases, what we see in our reporting and surveillance tools is definitely not the true prevalence. But we just have to keep working on increasing our testing rates and education and awareness to be able to get people tested. But that's a great point. I think continued community conversations and collaboration will be key to catch some of those cases that are not coming through our traditional system.
Thanks.
Great point.
Who else has a question in person? Anybody? And here's a question. Has home self STI testing impacted the collection of data? And I'm not sure. Maybe one of our staff have that answer.
Maybe one of the STI team members. From my understanding, that is still to be determined. I think it's going to have a potential like really great impact, but it's still very early to see truly the impact it's going to have. But I'll hand it over to if anyone.
Here's Brandon Kufalk with our
Perfect.
STI
Thank you.
unit.
Gracias. I can say that right now, most of the cases that we receive in WEDS, as far as reactive test results, are not at-home testing. At-home testing may someday have an impact on our numbers, but the reality is that it's expensive. I know because we're paying for some of it. And so at this time, until at-home testing probably becomes cheaper, we're really not going to see an impact on our morbidity and the numbers that, Dr. Zapata had shown. But someday that might happen.
Yeah, and we also have the State Laboratory of Hygiene here at a session, and that might be a question for them as well. But here's another question.
I just have a quick comment about the at-home testing. I'm from Outagamie County, and we have a public health vending machine where we have free kits for people to come and take them. What we have seen is there are little glitches with having the test done and sending them in on time, and they will refuse the test. So we are trying to get messaging to the client so they understand test and get it in the mail or what have you. So we have found that as a bit of a challenge, but we are trying to get some free test kits out to people. So just FYI, that's what we've seen early on in our situation.
Thank you so much. And thank you, Dr. Zapata. It's been amazing to have you here virtually. And we need to go to our break now. So we will have a 15-minute break.
All right. Thank you, everyone.
Again.
Take care.
Yes. Bye.